جزيلا لأسرة معهد الكلى في دمنهور على الفرصة وعلى تكريمهم لاسم الدكتور رشاد برسوم. To start with, it is to share with love. Early recognition of kidney transplant recipients with failing allograft is critical to appropriately plan for transition of care. Transition of care means dialysis initiations or preparing for second transplant. The top 3 factors determining the immune suppressive medication management with or without graft nephrectomy will be candidacy for subsequent kidney transplantations, residual kidney allograft functions, and complications from an over-immune suppression state. Optimal practice for tapering immune suppression medication is unknown. A recommendation to minimize potential complication from over-immune suppression, but still suppress immune reactivations and maintaining residual kidney functions and urine output. The palliative care for such patients is very important. A common refrain among patients who have been newly transplanted is that they would rather die than go back to dialysis. Although not always ultimately true, such a statement emphasizes the significant emotional trauma that can accompany the failing allograft. لو اتكلمنا على الجرافت سرفايفل ريسنتلي ده الانيوال داتا ريبورت اوف يونايتد ستيتس ريجستري اوف ترانسبلانتيشن. الجرافت سرفايفل في المير يير اتحسن جدا ووصل تقريبا ل 98% في سنه 2019، وال5 يير سرفايفل وصل لحوالي 88% في سنه 2015. This is very promising data, but it is inevitable that despite improvements in the graft survival, failing grafts will become progressively more common. It is estimated that patients with failed transplant currently constitute approximately 4% of incident dialysis populations. منهم حوالي 1% من living donor و 3% من deceased donor. Care of the failing graft. Alongside this increase in absolute number of failing graft, still there is an evidence that kidney transplant recipients with poor graft functions receive suboptimal care when compared to patients with native renal disease. Allograft loss is associated with a high burden of psychological and medical comorbidities as the patients faring poorly across many traditional measures of quality of care. Transplant ESRD patients have worse quality metrics in terms of anemia, phosphorus, calcium, albumin compared to native ESRD patients. We can see for the first year, hemodialysis patients with transplant ESRD had 9.8 up to 18.5 lower rates of at-goal hemoglobin achievements. For phosphorus, transplant ESRD had 6.3 up to 12.2 lower rates of at-goal of phosphorus compared to patients with native ESRD. It is the same for albumin and calcium. Hospitalizations, there is 1.5-fold higher risk of infection-related hospitalizations in the transplanted ESRD versus native ESRD. And for mortality, the high risk of the mortality on dialysis with failed graft is seen across a full spectrum of age, starting from 18 years up to 70 years of age with or without diabetes. Includes nearly 70% or three-fold higher risk in infection-related mortality, even more than the cardiovascular mortality. Transition of care. Transplant failure often comes with complex management decisions, such as when and how to wean immune suppressions, and the start of the transition phase to second transplant or dialysis. These decisions are made in the context of important concerns about competing risks, including sensitizations, residual kidney functions from one side versus infections and malignancy on the other side. Only minority of the patient with failing allograft will receive preemptive transplant or be prepared with vascular access for dialysis. Surprisingly, around 65% of patients with transplant ESRD starting dialysis with central venous catheter, 27% with arteriovenous fistula, and 6.9 with arteriovenous graft. Unfortunately, these patients are usually followed closely by transplant physicians. study تانية موضحها حاجة غريبة شوية. There was a 6.2 higher rate of fistula use and 8.3 lower rate of catheter use among patients with transplant ESRD compared to native ESRD during the first quarter. But this was explained. Some transplanted patients kept their arteriovenous fistula functioning even through the transplant phase. So when they resume dialysis after allograft failure, they resume it with their previous fistula. And this is explained later through the quarter 2 and the quarter 3. Although transplant ESRD started with a higher rate of fistula 6.2, but in the following quarter, transplant ESRD patients had 3 to 7.2 lower rate of fistula use in subsequent quarters. Second transplant or resting for repeat kidney transplantations, percentage of the transplant after failed allograft. The blue graph is showing the transplant recipients with a failed allograft, and the green one is showing the percent of the second transplant, and this is showing despite having successfully navigated the system for their first transplant and having established the relationship with the transplant center, preemptive second transplant is less frequently than expected, maybe due to socioeconomic causes or otherwise. First step is immune suppression management. Immune suppression management is one of the most important and complicated aspects in caring for patients with failing and failed allograft, giving the potential for affecting the probability of repeat transplant, protecting the residual kidney function, and preventing the development of graft intolerance syndrome, which can be both painful and precipitate the need for a surgical interventions for graft nephrectomy. Most compelling reasons to withdraw immune suppressions and its consequences. The increased risk of the infection, malignancy, complications associated with long-term corticosteroid immune suppression use, and difficulty inducing of some immune suppressions with a patient with renal failure. The consequences of withdrawing immune suppressions may be precipitations of the rejection, possibly requiring a transplant nephrectomy. Secondary adrenal insufficiency, if there is complete steroid withdrawal, loss of the residual renal function, potentially adverse immunological effects among those pursuing another transplant. It is a risk versus benefit equation, but this risk-benefit calculation is not one size fits all. The two major impacts is a retransplant candidate and the residual renal function. For the retransplant candidate, we need to focus to avoid sensitizations, avoid graft nephrectomy, and accelerate preemptive transplant as much as we can. And for residual renal function, we need to avoid rejection, avoid graft intolerance, and facilitate transitions to dialysis by choosing the modality and creating arteriovenous fistula. So, keeping immune suppressions adjusted to GFR. But if you have added immune suppressive complications like infection, malignancy, or progression of atherosclerotic or metabolic complications of immune suppression, so you need to personalize the reductions up to complete withdrawal of immune suppressions after allograft failure. In terms of a choice of agent to withdraw and schedule to tapering, based on the currently available data, the anti-proliferative agents such as MMF or azathioprine should be stopped before the other agents as the patient started dialysis. Anti-proliferative first. Next, personalized approach to tapering CNIs may be by 50% or achieving the lowest trough level based on the factors such as perceived infection risk, residual renal functions, and the availability of repeat transplantation. For steroids, there is a little guidance for tapering of prednisolone. Tapering to a minimal dose necessary over the first 6 months after graft failure. Decisions and the timing of prednisolone complete withdrawal should be done slowly and based upon individual needs of each patient. But there is another approach for CNI elimination first before anti-proliferative. In some cases of marked acidosis with failing graft may be the choice of eliminating CNI first, but with concern for DSA if there is a intention for a second transplant. mTOR inhibitors can be tapered slowly in a similar manner as CNI. However, much less data exists for mTOR inhibitors. Although reduced immune suppression may be counterintuitive in some individuals, such as those with ongoing chronic ABMR, that may contribute to more rapid loss of the allograft. One strategy to consider in such a patient is a late convergence of platelet-based regimen, which may allow for an improvement in kidney functions and retard the rate of decline, still with poor evidence. This is an example for strategies to reduce immune suppressions. It's based on GFR or residual function first. So the first example was GFR more than 20. If the patient is candidate for retransplant, so close monitoring of levels of immune suppression and its side effects, optimize CKD management including blood pressures, anemia, and secondary hyperpara, and routine malignancy surveillance. If the patient is not candidate for retransplant with GFR more than 20, still the same management. Failing a transplant with declining functions approaching blue 20. If the patient is candidate for retransplant, when eGFR approaches 20, establish baseline BRA value. Transplant enrollment management, mean evaluation for cardiovascular risk and vascular evaluations by Duplex and so far. Discuss options for decreasing or accelerating time for transplantations. Refer for vascular access if no living donor is available. Consider reduction in immune suppression to decrease the side effect and complications. If it's not a candidate for retransplant, so establish vascular access, coordinate reduction in immune suppression over time by reduction in antimetabolite initially by 50%, maintain CNI plus or minus low dose prednisone, monitor for graft intolerance syndrome. Failed graft with return to dialysis and patient is candidate for retransplant, monitor BRA every 3 to 6 months, taper immune suppressions, reduction in antimetabolite by 50%, maintain CNI plus or minus low dose prednisone. 3 months after initiation of dialysis, you need to stop antimetabolite, maintain low dose CNIs plus or minus low dose of prednisone. 6 months post dialysis, reduce CNI by 50%. 9 months, consider additional reductions in CNIs or maintenance of prednisone 5 mg. But at 12 months, you need to consider cessations of all immune suppression if no signs of graft intolerance syndrome and no significant increase in BRA. Continue monitor for sensitizations while waitlisted. Patient on dialysis, no intentions for second transplant, taper immune suppression, stop antimetabolite, taper CNIs by 50%, maintain low dose CNIs and or low dose prednisone therapy for 6 to 12 months. Monitor for graft intolerance syndrome every 3 to 6 months until patient is completely off immune suppression. What is graft intolerance syndrome? State of chronic inflammations due to immunological intolerance secondary to immune suppressive withdrawal with subsequent rejection to the failed allograft that left in situ. GIS symptomatic rejections has been reported in 30 to 50% in patients within the first year of allograft with immune suppression withdrawal, regardless the protocol used for immune suppression withdrawal. Symptoms is mainly gross hematuria, fever, malaise, and allograft enlargement and tenderness. The management. This is very important to differentiate. It is GIS or infections or malignancy before decide the treatment. The medical treatment initially is high dose steroids. They are the mainstay for the treatment for a number of cycles, which is different according to transplantation centers. But despite this medical management, most individuals with symptomatic ultimately require surgical intervention with graft nephrectomy. Immune suppressions and sensitizations. It has to take into consideration a few tips how immune suppression reductions may affect sensitizations. It's likely interval before subsequent transplant, which prioritize the most sensitized of patients to help mitigate the effect of sensitization in access to the future transplant. Complete withdrawal of immune suppression is associated with high risk of the formation of human leukocytic antigens. Keeping minimal doses of immune suppressions may still protecting. Interval over which the immune suppression was weaned appeared to be influential, and the immune suppression taper may be also need to be individualized on the basis of how many mismatches between donor and recipient before transplant. Type of mismatch also affect. Ablet mismatch as more precise the whole antigen mismatch to the risk stratify patients to develop DSA during a transplant, and it is still may also prove to be useful tool to guide immune suppression management upon graft failure. For residual kidney functions, losing the kidneys or graft based on immunological reasons have a bad impact or more impact in increasing the declining of the graft functions. For those CNIs may be beneficial. Higher mortality in patients due to infections and cardiovascular metabolic disorders, infection-related malignancy, and sometimes venous catheter-related infections. Allograft nephrectomy. The role of the allograft nephrectomy remains controversial. The indications is hemorrhage, acute arterial or venous thrombosis, graft intolerance syndrome, and controlled hypertension. But some physicians advocate that graft nephrectomy may be done for prophylaxis for graft intolerance syndrome. The comparison between اثنين groups من patients whom underwent graft nephrectomy will other keep their graft after failure. A patient who did not undergo surgical removal of the allograft had worsening anemia, more erythropoietin resistance, and lower serum albumin, and higher inflammatory markers. Later on, 2/3 of those patients had persistent symptoms and ultimately required nephrectomy. After nephrectomy, we can see that there is a marked improvement over 3 months and 6 months for erythropoietin resistance, for albumin, and for inflammatory marker CRP. Potential benefits of nephrectomy must be weighted against the risks of the procedure, surgical and sensitization. Again, it's not one size fits all. The evidence that removal of the allograft generates a donor-specific antibody independent of the immune suppression withdrawal. Level of BRA ranged from 10 to 50 to 55 in patients without allograft nephrectomy compared to 20 to 72 in patients who underwent the procedures. Advantages of the graft nephrectomy and its consequences: prevention of graft intolerance syndrome, possibility of immune suppression withdrawal after graft nephrectomy, but this can cause HLA antibody sensitization. Resolution of the graft-related symptoms or risks, but this is may add to loss of the residual functions, including the erythropoietin production. Giving a room for a new graft, but this is on the expenses of surgical morbidity, 5 to 48%, including bleeding and hematoma and even mortality. The impact of graft nephrectomy in the next transplant. There are several studies have also evaluated the effect of the allograft nephrectomy on complications related to repeat transplant. Patients who underwent allograft nephrectomy had higher risk of delayed graft functions, acute rejections of the allograft in the second transplant. This is maybe to blood transfusion during the surgical procedures or the sponge-like effect. Kidney may behave like a sponge that attract and absorb formed donor-specific antibodies to their antigenic targets, preventing detections in the serum. Also, surgery may engender an inflammatory response that promotes antibody formations in the setting of mechanical manipulations, remnant allograft tissue, and increased exposure to antigens. Some, at the end, still some advocate for preemptive nephrectomy in the patient with graft failure within the first 12 months post-failure. For impact in patient survival, there is 6 studies to detect the impact of graft nephrectomy on patient survival. Only one study have a statistical significance. Renal allograft embolization. This is percutaneous allograft embolizations is emerged as an alternative to nephrectomy and may be associated with lower morbidity and even lower mortality. Although the common post-embolization inflammatory syndrome can usually be managed with analgesics up to 20%, but still some patients may require surgical removal for persistent graft intolerance syndrome. The last stage is the CKD management and the dialysis management. The most important that initiation of dialysis is determined by patient symptoms and estimation of GFR. Several limitation for GFR estimation equation in transplant ESRD. For MDRD and CKD epidemiology equations, they do not perform as well in patients with transplant failure compared to with native failure. Cystatin C based equations was hindered by lack of standardized AC and constantly demonstrated superiority. modality of dialysis, while the time courses of the kidney function deterioration may be slower, is predictable. Sometimes clinicians paying effort to salvaging the remnant of. Yes. Appropriate planning, including modality, counseling, and the use of the peritoneal dialysis has been shown to be associated with improved early outcomes. Finally, the take-home message is what all mentioned, but the most important is never forget that they would rather die than go back to dialysis, so make it easier for them. Thank you.